Good evening, friends. I think everybody knows Dr. Sachin. He is a very accomplished minimal invasive and bariatric surgeon, and he has already presented, I think, 2-3 times in our forum. And today's topic is metabolic surgery. So after the Revalses came into the market, there was a lot of halla gulla, I will say that where will be the now bariatric surgeons. Then came injections, semaglutide and injection Monjero. But still, I feel there is a role of bariatric surgery because injection semaglutide or Monjero will have effect till you are taking injection. And let us learn from the accomplished bariatric surgeon, Dr. Sachin, whether bariatric surgery has permanent effect or not. Because some bariatric surgery may have temporary effect like sleeve gastrectomy, but some bariatric surgery, as Dr. Sachin will elaborate, may have permanent effect. So you will not require, there may be weight regain, maybe 10%, but then there will always be at least 20% permanent weight loss. So I leave it to Dr. Sachin. Is bariatric metabolic surgery the long-term solution for diabetes? So I will request you to just include your talk. What will be the role of injection, semaglutide or Monjero also? Thank you. Thank you.
Close it. Good evening, everyone, and welcome to CME. It's a privilege to be standing with so many senior, knowledgeable physicians and across a diaspora of many talents. Obviously, this topic is very close to me. Generally, I'm known to be a minimal slide presenter as a minimal access surgeon. I don't like to put too many slides, but in this topic, there would be some slides which are pertaining to some statistics which will reveal the theory behind metabolic surgery. So, without much ado, I would like to dive into it shortly. The agenda is today to understand the statistics, the pathophysiology, and to know the power of metabolic surgery. A small history: 1925, the first surgeon who accidentally did anal gastroplasty or colpoplasty with a diversion. The patient was diabetic, and he was an American surgeon. And in 1925, what happened that over a year, the patient came back to him that my sugars have reduced. I'm getting bouts of hypoglycemia. And the surgeon was astonished, and he was like trying to understand the pathophysiology. He said it's not related to my surgery, but eventually down the line, it showed a remarkable difference in diabetic patients. And continuing the tradition, Dr. Rutledge, who is known as the father of mini gastric bypass, who recently passed away, also did an accidental surgery for mini gastric bypass for a gunshot wound. The antrum was pelted with bullets, so he did a life-saving surgery. He cut the antrum off, and he joined the ileum to the remaining part of the stomach. And from there, this term of mini gastric bypass started. And from 97 till 2024, the surgeon was doing surgeries, performed miracles, and on a groundbreaking International Diabetic Federation podium, he presented 2.5 lakh surgeries where diabetic was gone into remission or made into normal euglycemia. Overcoming the prejudice, because everything which starts comes with a push. There is a little bit of stubborn reaction in our brain not to accept anything new. It is always that we work with evidence-based medicine, just not on pure hearsay of what surgeons are saying. And today's topic is not to showcase the excellence of a surgeon, but to showcase that today, as physicians and surgeons who are the flip sides of coin, now to have to be the same side of the coin. We need to go hand in hand to treat the patient. The understanding, morbid obesity is the fourth non-communicable disease today after diabetes. and its prevalence is about 30%, predicted to increase to 40% in 2027. And metabolic surgery is now known from bariatric surgery or weight loss surgery is now proving to be an effective treatment for type 2 diabetes. In clinical trials, they have shown remission with dramatic improvement. There are some random controlled studies in the last 20 years which are showing outstanding results. We have certain fixatures like BMI greater than 35 and sometimes BMI less than 35 to treat diabetic patients. Have we established that is it one of the solutions for diabetes? We look forward into this. The pathophysiology is that glucose hemostasis after bariatric surgery remains crystal clear on how glycemic control can be improved. We started with banding, then we started with sleeve, then we started with Roux-en-Y, and now we're doing mini gastric bypass. I'm jumping straight into the statistics. If it's not very clear, but I'll be trying to tell you, in AOB's Journal of Index, the patient of success rate for obese patients with type 2 increased to 439 million by 2030 and to 650 million cases by 2040. That's staggering amount of diabetic patients in the world. The pharmacological approach to treat diabetes has expanded considerably, yes. In India, a recent study showed that only 52% of patients with type 2 diabetes maintain HbA1c according to 7, and 19% reach the goal with LDL less than 5.6. Blood pressure by 138. Now, with the current literature, we have shown that there is a 77% remission rate in 14.6 months of follow-up in 2004 in a meta-analysis of 22,000 diabetic patients. 77%, that's quite a huge number. And a Swedish obese society compared different bariatric operations with conservative managements in groups, out of which 72% of surgical patients experienced remission of type 2 diabetes versus 21% in the medical group. The risk of diabetes was 3 times lower, the rate of recovery was 3 times higher, and the remission of glucose was less than 100 milligrams deciliter and no diabetes medication needed. And the biggest, I think the biggest control study ever done in the world was the Stampede study, which was done by Johns Hopkins on mini gastric bypass. And in 150 obese patients with uncontrolled type 2, the percentage of patients who reached primary endpoint, that is HbA1c of 6, at 1 year was 12% in the medical group, 42% in the Roux-en-Y, 38% in the sleeve, and roughly 60% in MGB. This was a phenomenal trial published all over the world. And a new era, because now we are collecting a lot of data for mini gastric bypass. We have a lot of data from RCTs where they are showing remission and also resolution in type 2 diabetes from a BMI between 30 and 35. There is a lot of controversy whether can we use it for type 1 diabetes where there is an autoimmune disorder. For non-obese patients, it doesn't work. But in type 1 diabetes with obese patients, the sugar might come under control, but still insulin is needed for type 1. But in type 2, the mini gastric bypass also has a criteria that we see remission and resolutions of type 2 reversal diabetes in diabetics who are less than 5 years. We have a phenomenal record of 87-70% in it, but anything going above 5, 10 years, 15 years of diabetic patients, the remission and the resolution has got its own subjective data. So the second Diabetic Surgery Summit held in Washington in 2016 introduced new guidelines that they will consider metabolic surgery among anti-diabetic treatment. As a result, in 2017, the guidelines were incorporated and metabolic surgery, including bariatric procedures which are performed, is now considered as a standard diabetic treatment for selected individuals with poorly controlled type 2 diabetes. Johns Hopkins is the Mecca in Medina, and we follow suit with it. As I said, the 2016 Diabetic Summit with Johns Hopkins, they conducted a study, and a joint statement of International Diabetes Federation, UK Federation, the Chinese Diabetic Society and Diabetes India called for bariatric surgery to be considered in patients with class 1 obesity and inadequately controlled hyperglycemia despite optical medical treatment. In the largest study, over 1 lakh patients who continue to require insulin, the data which controlled 78.7% reversal. That's a staggering amount. And this was a controlled study done in John Hopkins. School, So, forgive me because we're doing the LED for the first time. So, नहीं इससे पहले बात नहीं बेटा इससे पहले जो स्लाइड था ना आपका हाँ ये बात इसको zoom कर हाँ इस if it is still little bit visible I'm sorry but basically with sleeve what happens is with sleeve we have increase in the GLP hormone, the GLP and reduction in ghrelin. That is the pathophysiology behind weight loss and type 2 diabetes. When we go to mini gastric bypass, again the GLP, the PPY and the DPP hormones are increased which helps in the resolution of diabetes. And coming this side, there is increase in the insulin secretions in beta cells with the gastric bypass as well as the Roux-en-Y. This is the main strength for us to get the diabetic achievement is the insulin sensitivity increases after the gastric bypass. The sleeve gastrectomy also was first found to be just a weight loss program, but now it is also showing malabsorptive symptoms and there's a duodenal hurry which increases the anti-incretin hormone and the GLP. So with sleeve also, we are not getting resolution but we are getting remission. We are getting HbA1c's lower as compared to the higher glycemic index before. Next slide please. Yes. So, मेरा स्लाइड ये आप हटा दीजिए मैं बाद में फिर से प्ले करूँ इसको प्ले कर दीजिए Bhatta, can you just start the slide again? These are some of the patients. We had a 250 kg patient with a mini gastric bypass. After 2 months, 110 kgs. We had a patient with 110 kgs and after 2 months we had achieved 76.5 kgs with a sleeve gastrectomy. So on and so forth, 122 kg, we lost 46 kgs in 3 months. We had an international patient, 125 kgs and after 2 months, 97 kgs. We do 2 types of surgeries at MASH. One is the resectional, that is the sleeve gastrectomy. This is where the hormone ghrelin is mostly in the fundus area. That's which triggers the hunger or snacking quotient of the patient, which is not in his control. So when we resect this part of the stomach, more than 80% of the stomach is removed, the fundus is removed and therefore the ghrelin hormone comes down and that achieves us the weight loss and the fast transitional food which goes into the tube and passes into the jejunum. And this is a mini gastric bypass which we are doing. We perform a sleeve, leave the sleeve inside, we don't remove it out of the stomach, it's still secreting its juices and a small pouch is created. A small pouch which is then connected to 200 centimeters of the jejunum. So there's a bypass. This is called the mini gastric bypass which Dr. Routledge had introduced in 1997 accidentally, and now this is the gold standard for patients who are getting BMIs above 39-40, super obese patients. with type 2 diabetes, and this is what is clicking the diabetic remission, and in some cases, over a period of 60 months, diabetic resolution. Just a small thing, we have the obesity pandemic map 2025. If you see, the complete country is under this pandemic, and triggered more in Chandigarh, Punjab, Haryana, J&K, Tamil Nadu, Kerala. We have reports where 12.6 million children are also affected by obesity in this country. This was a study done by an Italian surgeon, Goel et al. After his MGB in his patients of roughly 3.5 lakh patients, where the evolution of FGALC after roughly 60 months has come to 5. So this was one of the biggest study again done on the MGB forum. So sorry, I was not able to cut short too much today because I wanted some stats. So this study was done by an English physician in the Diabetic Federation, Dr. Porres and Dr. Shore. With the surgeons together, they did a study in which they followed up and showed 80% remission of diabetes and 67% resolution of diabetes in type 2 diabetic patients in obesity. Next one. इसका next. वो बड़ा वाला. इसको हटा दीजिए. दूसरा हटा दीजिए. एक वो वाला लास्ट ये. उसका ये लास्ट. zoom कर और ऊपर ले जाओ और ऊपर ले जाओ. This study is a recent study done by Dr. Jammu in Punjab, where he had done roughly about 3.5 lakh surgeries starting from 1996, a very senior surgeon, and he has presented his data on the World Forum, where MGB resulted in 87% of resolution of diabetes in his patients of type 2 obesity. Or एक last slide. दो वाला ये वाला ये दो. Next. And Dr. Chauhan, this is for you. So, in summary, no, the British Diabetic Society has not removed bariatric surgery as a treatment option for the resolution of type 2 diabetes. This is the recent update, and take this next step. I wanted to show one, it's not coming. So, I'm very happy to say one of my own patients, after a period of 8 months, she was 166 kgs with dyslipidemia, hyperlipidemia, and hypertension. She messaged me about 6 days back that her blood pressures are coming to 115 by 80, and she was on telmisartan and one more drug which she's not taking. So I told her to monitor and keep it for a month and then report to her physician. So that was the take-home message for me, that metabolic surgery is disconnected. Metabolic surgeries is a new revolution in India, and we are hoping a support. Disconnected. Just आप अपना disconnect करो. So sir, luckily my BP has come under control without medicine after surgery, and it's coming around 115 by 75. For me, this is a big pat in the back from the patient, giving me the theory that I'm on the right path. Thank you so much. I just wanted to end this note today. We are not, I wanted to have a one a very hard talk about this, that even if today physicians feel that, look, care is better than cure, in diabetic patients, at the end of it, the end stage of it, we're not able to stop the macrovascular and the microvascular problems, amputation, cardiovascular deaths due to diabetes, despite the best medicines, including the new GLP, Ozempic and everything. But with this surgery itself, we are stopping the complications. This is not a debate on whether diabetes is going to come under control or not. We are looking at the last complications which we can avoid with this surgery. And the best part about it is that even if you send me a patient, even if the diabetes needs to be treated or it comes to a remission, the patient comes back to you because it doesn't happen on day one. We are sending the patient back to the physician to control his diabetes till it becomes a cure. So that is my take-home message, that we need to go hand in hand, not as surgery versus medicine. Thank you so much for your patience. Thank you so much.
Thank you, Dr. Sachin. We'll have questions at the end of all the lectures. So basically, what he said, mini gastric bypass surgery particularly, they increase incretin effect and ultimately raise GLP-1 level, which we are anyway giving by injections. So this is natural GLP-1 you are increasing in the body, and that's why insulin secretion also. So we'll have question and answer at the end of both the lectures. So next speaker is Dr. Ankit Goel. He is also a very well-known urologist, and particularly he is adjunct director of urology department in Mass Hospital, and he will speak on management of kidney stones, particularly in complex scenarios. Dr. Ankit, can you start with that?
Hello.
Dr. Ankit, 15 minutes will be enough.
Finish in 10 minutes. Good. Thank you, Dr. Sachin, for a very elaborate topic like diabetes and special emphasis on surgical management. So in your routine practice, you must have encountered patients of kidney stones. So I'll be focusing today. There are some few challenging scenarios where a surgeon also feels this is a very difficult case for me to operate, even whether I'll be able to give a complete clearance for this patient or not. So I'll be focusing on my talk on this topic, and it will be a very brief presentation, especially 3 or 4 cases which I have done here at MASH. So what is a complex kidney stone? There is no exact definition of a complex scenario, but whenever we encounter a very large kidney stone, like more than 3 centimeter, 4 centimeter, in a complex anatomy, suppose a patient has a horseshoe kidney or a patient has an ectopic kidney, then it becomes very difficult for us to give the option of surgical management and give an exact choice of surgical management to the patient. So this is one case where this was a complete stag horn in both of the kidneys, and it was a horseshoe kidney. The challenge here in this case is the anatomy of the kidney. What we do routinely, PCNLs, the surgical treatment of choice for kidney stones, bigger kidney stones, is PCNL. But when the anatomy is distorted, what the surgeons do, we are not regularly seeing this sort of cases. But in a horseshoe kidney, the kidney comes very low. The poles, the upper poles become very lateral and the lower poles join in the midline. So it becomes a very difficult scenario for us to operate. Similarly, an ectopic kidney which is lying in the pelvis, and suppose the patient has a 5 centimeter stone, how to do it? Now a 5 centimeter stone deep kidney lying in the pelvis, you cannot do a PCNL, you cannot just go from the back and puncture that kidney, because standardly kidneys are located way above, around 11-12th rib, and you can easily gain access to the kidneys. So these are some of the complex scenarios and associated with a PUJ obstruction. It becomes very difficult for these cases to give a surgical treatment. So I'll share my few case profile, 3 or 4 cases. So so what are the different plans we have for these sort of patients? First is PCNLs for large stones, second is RIRS. Third is when we combine both of these approaches, so you can access the kidneys from the puncture of the kidney and the antegrade access. Then it becomes an ECIRS, that is called endoscopic combined intrarenal surgery. But for an ectopic kidney which is lying deep in the pelvis, you have to take the help of laparoscopy. So you cannot go and do a simple RIRS or a PCNL in that case. That is called lap assisted PCNL. So there are some of the videos. I do supine PCNL basically where there is no need for the patient to turn prone, because what we have been taught traditionally that the patient needs to be turned prone for PCNLs, but for last 3 to 4 years supine PCNL has come up in a very big way. And as Dr. Sachin told, there are slew of bariatric patients. So in a bariatric human body like a 150 kg old guy, it becomes very difficult for the anesthetist team, for the surgeon's team to intubate first and then let the patient become in prone position, then again do supine position. So the treatment of choice here is a supine PCL where you don't need to turn the patient prone, puncture the kidneys from lateral side, gain access into the kidney and remove all the stones. So this is endoscopic view of RIRS. That means you are going inside the kidney, there is no puncture or hole inside the kidney. You just gain access through the ureters. And I am doing here at MASH up to 2.5 centimeter stones with RIRS. The EAU recommends the upper limit as 1.5 centimeter, 1.8 centimeter. Very few urologists in the country are going above 2.5 centimeter or 2.8 centimeter. What armamentarium I am using is a suction access sheath, that is called a FANS sheath. So it has been recently launched 6 months back. The problem in bigger stone for RIRS is remaining fragments inside the kidney. So we cannot do a 5-hour RIRS inside the kidney. So what we do, the sheath we put inside the ureter has an attachment of a suction. So when you lace the stones, it becomes fragment, you attach the suction and it sucks out most of the fragments, around 99%. So this is the first case. It was a very difficult case. Like you can see in the CT, this is a right-sided hydronephrotic kidney. The size of the stone was 2.8 centimeter. I think the picture is not clear here. So the patient has got a ADPKD, adult polycystic kidney disease, and it was running in his family. So patient came to me with a 2.8 centimeter stone in the pelvis, and in this scenario, PCNL becomes very difficult because when you puncture the kidney, when you gain access into the renal pelvis, there are n number of cysts inside the kidney where you can get lost. So I offered him the RIRS, but telling him that he might need a second procedure because the shear volume of the stone is very large for IRIs. But I was able to do it in one sitting with use of FANS sheath, which I have told you. And this was the complete clearance post-surgery X-ray with the DG stent institute. So the position as usual was lithotomy, access was retrograde. Stone fragmentation, I am using holmium laser. The setting is 0.2 joule, 40 hertz, and it lasted around 45-60 minutes. So this was the issue, the polycystic kidney, and The advantage in RIRS is there is no bleeding, nil. The blood loss is, I'll say, nil. And the patient was discharged next day home. Just wait and watch for 2-3 days. I seek the help of physician and built up the sodium up to 120, 125 and did URS and PCNL in the same sitting for a staghorn and a lower ureteric calculation. And you can see this is the complete clearance post-op. So as usual, the patient was in prone position, retrograde and percutaneous axis. Bleeding was around 50 ml. When you puncture the kidneys, there is minimal amount of blood loss. That is expected. Post-operative outcome, there were no residual fragments. And the hospital patient stayed in hospital around 2 days post-op. This is a case number 3. This was a 60-year-old gentleman. You can see the volume of the stone. Can you see this? This was a 5 into 6 centimeter staghorn calculus in the pelvis. So this I have explained the patient. You might need 2 or 3 punctures to complete this, completely eradicate this stone. But I was able to do it in a single puncture. You can see this is the unplacked sheath we put. These are the 2 guide wires to remove each and every fragment of the stone. So this was standard PCNL. That means you dilate the tract to, when the shear volume of the stone is very large, around 5-6 centimeter, your tract size has to be much bigger because you want to retrieve larger fragments. Otherwise, your operative time will become very long. You cannot operate the patient for 5 to 6 hours in a prone position. So you dilate the tract up to 30 French, then you retrieve the stone and the surgery was over in, I'll say 2 hours. So bleeding was minimal, around 100 ml, and the patient was given complete clearance. So the importance of the tailoring approach, that you have to sit with the patient pre-operatively. I counsel them, see, there is no one single modality that is perfect for you, but I give the patient options. So if RIRS is not going to help you, I can convert the patient to mini PERC, but my main aim is to give a complete clearance to the patient for which he or she has come to the hospital. So the conclusion is complete clearance is achievable. The multidisciplinary approach, even complicated stones, can be managed effectively with a number of armamentariums which we have. Thank you.
We'll have just short presentation from Dr. Mohammad Adil. He is head of the Department of Anesthesia in Mass Hospital. And after his presentation, I will seek opinion of Dr. Avtar Kishan also. He is very senior anesthetist. So Dr. Adil, you can present yours.
So I'll just take 2 minutes to give a few words of appreciation for Dr. Adil. So I've not went to home. I'm just directly coming from the OR to this CME. So today was a routine day. I did a PCNL today. It was a standard case, staghorn stone.
Please maintain.
So staghorn stone, around 4 centimeter stone, standard PCNL.
Please maintain silence, please.
भाई नरेश बैक एंड पे जरा ये आवाज थोड़ी कम कर दो 5 मिनट का साइलेंस चाहिए ठीक है बात नहीं होनी चाहिए बिल्कुल भी
So old gentleman, around 65-year male, presented with a renal calculus, 5 centimeters staghorn, and it was standard PCNL. The surgery was over in 50 minutes with a complete clearance. But to my surprise, when I left the OR, I was sitting in the lounge, I received a call from Dr. Adil that the patient has developed a ventricular tachycardia. The heart rate is around 250, he is not maintaining the cardiac output, is not maintaining the BP. The blood loss was hardly 200 ml, not more than that. So I must thank Dr. Adil to manage that patient very meticulously. The patient was given the appropriate drugs to control the VT, otherwise he would have landed in a cardiac arrest. So you must be knowing how soon can VT turn to a complete cardiac arrest, and the cardiologist was a call away. The cardiologist came in 15 minutes, but we have a very narrow window of 15 minutes in which Dr. Adil took the care and the patient was given appropriate drugs, and now the patient is shifted to Goel. So I must thank Dr. Adil to take care of that patient. And
Just a small interruption. Dr. Mohammed Adil is the last inception in the feather of the cap in MASH. After his arrival, we have done cases which earlier were being rejected due to whatever reasons of high risk at our center, but we wanted to challenge this, that even at our center, maybe it's not a 200-bedded hospital, 300-bedded hospital, but with inception of Dr. Mohammed Adil, the bariatric program has gone from small baby steps to beyond leaps. He takes a very personal interest in each and every patient, whether it's a gallbladder surgery, whether it's a hernia surgery, ENT, orthopedic surgery. He is practically the backbone of our surgical team, and I think anesthetists have never been given their fair share of recognition. But I really wanted him to come and present today. He's done another wonderful job in one of my patients, and especially we did 2 days back a 198 kg patient with an MGB, and 9 hours after the surgery, Dr. Mohammed Adil made my patient walk. That is his dedication to this program. So I'm just handing over for just a single short slide of one of his recent achievements.
What is the surgery done here?
So Dr. Adil,
Mini gastric bypass.
intubation or anesthesia in difficult cases.
Good evening, everyone. I'm not just going to take so much time of you. So we had a case of difficult airway. Patient planned for lap choline. So patient is a case of post-mandibulectomy, and patient during the PACI versus patient having one finger mouth opening, so difficult to intubate such type of patients. So we have planned for such type of patients awake fiber optic. We have done laser intubation, and after that just in 15 to 20 minutes lap chole was done, and patient was extubated comfortably. Yeah, it was awake intubation. Thank you.
Thank you, Dr. Adil. So what he is saying, without giving muscle relaxant, he did intubation, nasal intubation, without giving muscle relaxant, awake intubation. So, Dr. Avatar, very senior anesthetist, any comment on this? Then we will take questions.
Not take much time. Of course, he's done wonderfully well, Dr. Adil. I will say 3 cheers for him. And one thing which I have noticed, which is not technically anesthesia member, but what Dr. Sachin said, nobody ever recognizes who the hell anesthetist is. They always say, if Sachin ke paas gaye, they forget that, I shouldn't say because being an anesthetist, more than 60% work is being done by anesthetist. However good surgeon you are, you cannot do well unless anesthesia is good. So, thank you very much.
Thank you, Dr. Poddar. Dr. Poddar, just take your seat. Just take your seat, sir, please. I would like to call my young brigade here, Dr. Vipul, Dr. Amish Vora, Dr. Biplav. Can you just please come here? I want to just come here. Just come here.
Please, sir, please.
So, मुझे अपने यंग ब्रिगेड से आपको इंट्रोड्यूस कराना है. प्लीज आ जाओ. मैंने डॉक्टर सचिन को, डॉक्टर अंकित गोयल को और डॉक्टर आदिल को सबसे इंट्रोड्यूस कराया. So, Dr. Amish Vora is running state-of-the-art oncology center in Hoskas. He is a DM oncology from AIMS, and he is doing wonderful work in private practice. One of the rare oncologists who has ventured into opening his own center and running it very successfully. Just one line from him.
Hope is EBITDA positive.
Absolutely. Dr. Vipul's father taught me in Safdurjung when I was doing my MD in 1986 in Safdurjung Hospital. He had just come out of AIMS after having his DM, and we had heard of his stories. Those stories I will not tell you right now. No, they were very positive stories that he was one person who had carried Harrison on his honeymoon. I don't know how true it is. I don't know. No. Vipul will be able to better tell it. Vipul has a state-of-the-art diagnostic center in Hoskas called Capital Diagnostic. He is doing wonderful work, does one of the best ecos. He's been trained in UK. His wife is a wonderful radiologist, Dr. Bimal Preet. Just one word.
I just like to thank everyone, especially Dr. Chauhan, for all the recognition, and hope to work with you very soon. Thank you.
Dr. Biplav, I called him today morning. I had a challenge today morning of attendance, and he called me, sir, आप जहाँ बुलाओगे ना, मैं वहाँ जाऊँगा. अगर चंद्रयान 3 में अगर मेरे को ले जाना है, मैं available हूँ बगैर training के. What kind of work you are doing, darling?
Sir, I am a gynae laparoscopic surgeon. I am doing the all advanced gynae laparoscopic surgery. Whatever difficult cases you want, I can do that. And I am very close. Thank you so much, Dr. Sushil sir, for giving me such an opportunity and such an appreciation. And I am very good friend of Dr. Sachin and Dr. Ankit also. And thank you so much for coming here. Thank you.
I hope all of you become part of their venture. Thank you, Dr. Amish, Dr. Vipul, and Dr. Biplav. We had a very wonderful session, and Dr. Sachin Ambekar touched upon a very sentimental topic for me. I am in love with diabetes ever since I was Dr. MPS Verma's house surgeon in Maulana Zad in 1985. Ranjan was my darling in my room. He was never interested in diabetes, let me tell you. Doesn't know ABCD of diabetes. He still asks me, यार blood sugar 126 है क्या करना है? मैंने कहा पहले 700 रुपए बेच फिर बात. So Ranjan and me are poles apart. But I went and became in love with diabetes, and I wrote in Dr. Sachin's this thing, that there are recommendations which do not recommend bariatric surgery as a class 1A recommendation for reversal of diabetes. Dr. Sachin Ambekar called me in between and said, Dr. Chauhan, please come, I want to show you something. And I would like to rebut him with questions from Dr. JPS Tulsi, the champion, the master, Dr. Anil Gupta sir, my teacher, 1976, MD Medicine from BHU, Dr. Sajid Parvez has his own input, and we are in for a very interesting question answer session, and therefore I first give it to Dr. S K Poddar to set the ball rolling, and then I am coming to each and every one of you for a very interesting question answer session. Just one request to all of you: before you leave for dinner, ask one question. And I assure you, next time when we are meeting on 6th of August, I will give you a better input.
So thank you, Dr. Chauhan. So as in his talk, he has already mentioned metabolic surgery is not bariatric surgery, not only for weight loss. It reduces blood sugar, it reduces hypertension, it may improve your cholesterol profile. So it's a metabolic surgery. And how does it reduce sugar? Basically, the mini gastric bypass is better surgery for obese persons in diabetic patients because it increases more incretin levels and more GLP-1 than sleeve gastrectomy, because the food comes directly to the ileum where L cells secrete GLP-1. So I will not ask any questions. I leave it to the our audience to start questioning.
Dr. Anil Gupta sir. Sir came on a very special request. He was very busy.
First question only for Dr. Sachin only. First question for Dr.
Yes. And Dr. Anil Gupta sir is only 16-year-old. He did his MD medicine in 1976. And sir has stopped growing after that. Sir, your question. Yeah. Dr. Gupta के लिए एक
Sir, earlier for grossly obese people, the only option was bariatric surgery. Earlier for the grossly obese people, only option was bariatric surgery. But now with the advent of this Wegovy and Moderator, another channel is opened, and now I think both will go together. There are large number of people who after bariatric surgery, they again after bariatric surgery they again gain weight, and then in that scenario Wegovy and Moderator again come in the picture.
So,
Input on that.
no. So what sir is saying is that even after bariatric surgery, Dr. Sachin, that is not the panacea. We still have to fall back upon medications. So is दे दो ना यार, कुछ खाया पिया करो ना यार, कुछ खाते क्यों नहीं है?
Hello. So, very apt question. In the journey of any surgeon, especially who deals with pediatric or metabolic surgeries, outcomes are always not very happy, not always 100%. As I said again, we have to go hand in hand. We have patients after sleeve gastrectomies who regain a certain amount of weight, where there is a dilated pouch. We have certain amount of patients even after the mini gastric bypass who have a certain amount of weight. The recent trials now done in the US and the diabetic FDA are also recommending GLP-1 injections post bariatric surgeries or sleeve gastrectomies after 1.5 years if there is a regain, instead of going for a second redo surgery. So the amalgamation is very important. As I told, the end result of today's CME is that it is not we are opposing factors, we are hand in hand to cure the patient, where earlier diabetes was always care and not cure. So this is what is, again, there is no hard and fast rule for anything today. I mean, if I say, okay, it's 100% result, no, it is not, obviously. But there are beautiful results which are helping in the remission. The resolution may take time or may not take time. And the GLP-1, as you said, Wegovy, Mounjaro, semaglutide, right? They all work on the same system. That is your incretins and your increase of GLPs. So it goes hand in hand. And we, in fact, Dr. Jammu is one of the biggest statisticians for MGV in India. So he's now starting a series of MGV with Mounjaro.
Great.
After 5 years.
Right. Dr. Sajid Parvez is my batchmate. He has huge practice and huge fan base in Central Delhi. I think only probably lesser than Mr. Modi.
Sir, good evening. Wonderful presentation.
Thank you so much.
I must congratulate. But recently we have been seeing a spate of young adults who are obese and who are in for a long duration of diabetic treatment.
Right.
Is there any primary indication? I mean, what is the level of indication for such patients to go in for a bariatric surgery and later on followed by a little bit of medication?
Level of recommendation of bariatric surgery for reversal of diabetes in the young population.
In young population who are facing a challenge of diabetes and that is going to stay lifelong. Why can't we start with bariatric surgery? What is the level of indication for such patients?
We are already in India. It is being started in Punjab for reversal of type 2 diabetes in patients less than 35, the BMI. So the BMI is the indicator for us to treat patients. These studies are also now being done for BMI less than 30.
Any exclusion criteria?
Exclusion criteria are if the patient is recently diabetic, is diabetic for more than 10 years, then he should have a BMI of 30 to 35.
Any other exclusion criteria for bariatric surgery?
No. I mean, apart from that, except the type 1 diabetes, nothing else.
All right.
And just a small thing. Again, the remission of diabetes is better maintained, we have seen, in patients who touch a BMI of 35. Between 30 to 35. Not obese. I mean, obese patients give a better remission. as compared to patients who are not obese. There is a remission, but it takes a slow progressive time, which may need again insulin or whatever medicines to be dependent, but they go hand in hand together.
But right away starting with bariatric surgery, there is no criteria or no comment on the...
Only if, as I said, if 5 years and above the medications have started and the HbA1c is not getting into control. Not getting into control.
Primary thing is it's not getting into
So
control.
the first step is again the medicines. If the remission is not happening, you're not achieving your try point of HbA1c, LDL and the rest of it, and it is still going overboard and you're putting more medications, then yes, then it comes as a second option in non-obese patients.
In non-obese patients. If the patient is already obese, then we can have a reverse.
Yes.
Okay.
Right. Not the last word on remission of diabetes. I am sure the masters on the first table will have some different thing. Dr. Suman Sharma ma'am, anesthetist. Sumita Sharma ma'am. Yes.
Sir, I think there is a little difference in criteria selection for bariatric surgery and metabolic surgery. I think BMI is not the criteria foremost in metabolic surgery. It is to correct the surgery is done to correct the metabolism. I think lower BMI people are selected for this surgery, metabolic surgery.
Ma'am, metabolic surgery is recommended for patients who are getting the BMI from 35 onwards with type 2 diabetes. Obesity is not a singular effect, it's a concomitant of bouquet of diseases. Right? So when we talk about metabolic surgery per se, it has to be achieved with weight loss. Only then the criteria starts coming in. So the criteria is again BMI, the disease, the cofactors of your HbA1c and the longevity of the disease since when it has been hampering the patient. So that is how we select our patients for bariatric.
There is one more term, healthy obese. So BMI, do you think it's the fallacious metric to really measure the...
How do you define healthy obese in what terms? In weight?
Yeah, BMI will include the lean body mass, the bony mass, the
Ma'am, when there is an adiposity of the tissue all over,
yes,
the skeletal muscle also gets adiposity. So it's an overall effect.
Obesity is basically adiposity.
Yes. But it is internal and external both.
Yeah. Internal as well as
think what she means,
it is the change in the cell fatty and the positioning
fatty
of
acids. Yes.
So I think you are mentioning some, I think I heard Dr. Anup Misra also, he mentioned that obesity diagnosis in healthy, what you are saying healthy obese can be done by MRI, but that is not standardized, I think.
Not standardized.
It's not standardized. MRI for to diagnose obesity, I think. He mentioned somewhere, and he also mentioned waist circumference better than BMI. He presenting a paper waist circumference more than 80, and in a male waist circumference in female 80 and in male 90 is obesity, whatever may be the BMI. Yeah.
Haji, Dr. Avtar Krishnan sir.
You said that diabetes is cured. Cured means cured for life?
Yes, sir.
No,
not needing medicines further.
No medicine required ever?
Yes, sir.
Thank you.
Great sir. Actually, जब मैं मैसेज भेजता हूँ तो डॉक्टर सविता सचदेवा का थम्स अप आता है, मुझे पता होता है कि मैम आएंगी आज, पक्की बात है। आज मैम का थम्स अप नहीं आया, तो मैं घबरा गया क्योंकि आज वैसे भी मुझे बहुत चैलेंज था, तो मैंने आज डॉक्टर संजीव सचदेवा सर को फोन किया। मैंने कहा संजीव यार आज जरूर आ जाना, मैडम का थम्स अप तो आया नहीं, एंड ही सेड यार आज 100% आना।
नहीं सर, आप बोलेंगे तो वैसे आऊँगा, बहुत डरता हूँ। इंटर्न था इनका, एक बार जिंदगी में भाग के पिक्चर देखी है, टॉप गन, पकड़ लिया था इन्होंने, बहुत डांट पड़ी थी उस दिन सब बजाने में। टॉप गन। Sachin sir, just one question. We are talking about all the good things which happen after these surgeries, but there are complications like the dumping syndrome, bacterial overgrowth. Are they the same as they had in Roux-en-Y and all in this mini gastric?
No, sir, right now the mini gastric bypass defines something like a dilated pouch. Everything was small in the earlier surgeries, including the sleeve. It's a tubular structure. It's a forced structure. Think of this as a wide feeding jejunostomy. The pouch which we create, so for a basic understanding, we put a bougie into the stomach, which is like a 38, 36 French, and we fire the staplers closer to the bougie, forming that tube. Chota ho gaya. So this is a forced entry, where dumping can happen. As you said, gut flora can be, they have farting issues, to be very honest. So, or let's say bile reflux. But with the mini gastric bypass, when we put the bougie, we are 3 centimeters away from the dump. It's a wide pouch. So he's eating, in fact, with MGB, after a year he can eat even a pizza. Not in a sleeve. There are recommendations because carbs cannot be taken in. Carbs ka breakdown nahi hoga, so he will vomit. So automatically he forgets the French fries. That's how the weight loss is maintained with the intestinal hurry. But with a mini gastric bypass, actually he can eat anything and not put on weight. Yeah, so there is a huge, so there's no dumping syndrome because pouch bada hai, everything is going and transitioning straight into the ideal.
Thank you, Dr. Sanjeev and Dr. Savita for coming, first of all, and for the wonderful question that you asked. Dr. Vipul? Healthy obese.
Hi Dr. Sachin, thank you for a very informative presentation first of all. One thing I wanted to have your take on, there's something called accordion procedure that's basically an endoscopic sleeve.
Correct.
What is your take on it, number one? And number two, what is the actual long-term benefit if you go for an accordion? Thank you.
So as we said, every day there is some brainy guy deciding that, okay, I can go a little more better. So that's how, we keep going into the surgical aspects. Endoscopic sleeve gastrectomy started in 2001 in France. But it had dire results like marginal ulcers, reflux, and tightening, which need to be opened. So there are certain surgeons who have got this expertise, especially Dr. Mohit Bhandari in Indore, who's doing quite a bit of this. Series are yet to come, but again, reflux is an issue in this. Marginal ulcers because of the stapling and inversion into the mucosa, whereas the staplers are outside the stomach in the conventional one. So it's easily taken. Mucosa gets ulcerated. So that is one, I think, another aspect where we need to watch out. It is giving good results because again, there's no cuts, there is no, post-operative complications from anesthesia point of view and everything of that sort. So it has got its plus and minus, but yes, it's too early to actually comment whether it's going to be beneficial or it has any cons. But again, it's marginal ulcers which are a problem in it and reflux. But it can be reverted.
Dr. Amish Vora.
Hi Dr. Sachin.
Hi.
So one thing what ma'am was just mentioning about the obesity or adiposity, I was just reading and there's something called as type 5 diabetes, and which happens only in malnourished and lean individual. So not everything is associated with obesity in life, and I truly believe, not like looking at my size, but I truly believe that there is something called as healthy obese also.
Right.
Now the question is, Tulsi sir always loves to quote some papers, so I'll also quote a paper. JAMA 2024, there is a 10-year follow-up of bariatric surgery versus medicine-directed diabetes control. They found 12% of patients, like sir asked the question about cure of diabetes, who never required any treatment after that. When they subdivided, they found that it all depends on the number of anti-diabetic these patients were taking, BMI at the baseline, and HbA1c at the baseline. In your experience, who are these patients whom we should refer almost compulsorily to you for curing their diabetes?
Since we're doing a lot of mini gastric bypass, for me the criteria per se, because as you know, there are guidelines. At the end of the day, every surgeon is very finicky about what he picks and chooses. But more or less, you need to follow a steep path where you're not diverting from the basic idea. So for me, any cure for diabetes above the BMI of 325, not complying with medicines, HbA1c hovering above 8, 9, not coming down, we think in perspective of not only curing diabetes but the complications further. The cardiovascular, the amputation. So for me, mini gastric bypass is a clear indication for an obese patient with non-compliance of his statistics with his medicines and the HbA1c.
No, Dr. Sachin, I get your point. What the criteria you just now said are like desperate measures for the gastric bypass or surgery.
Right.
I'm talking of an ideal situation. Say for example, somebody's HbA1c is 7.3.
Right.
Only 2 anti-diabetic drugs are there, and BMI is 27.5. 27 is the lower cutoff of taking the gastric bypass according to international guidelines. Is that person the right person for gastric bypass? Because papers after papers have shown that gastric bypass is slightly always better than only medical management of type 2 diabetes. Should we intervene early? That is my main question.
No, because as I told you, the criteria was that there are studies going less than 30, but with that there is a malnutrition syndrome. So we have to choose. Again I said, for type 2 diabetes, non-obese patients, the studies are that less than 5 years and less than 30, the criteria can work. But it is not still established in remission of it.
Dr. Amis, I think we should not promise that bariatric surgery will cure your diabetes. We should never promise. It can be there, remission, but we should never say before surgery that it will cure your diabetes. It will help in management of your diabetes. We should never, it's a medical issue. You should never promise it will cure diabetes, I think.
Dr. Poddar sir, Dr. Saurabh Bansal, who has been part of the group for last 5 years now. He has gradually captured our imagination. पहले गुल, फिर गुल बदन, फिर गुलिस्ता हो गए. आहिस्ता आहिस्ता वो मेरे दिल का सामा हो गए. He has a question.
Sachin, very nice presentation. I couldn't see it, but I was listening to your answers. So, one thing somebody asked, what are the contraindications for doing a bariatric surgery? So, in a young patient, when you find any features of early cirrhosis, that is a clear-cut contraindication of doing a bariatric surgery. You should never take a risk of doing any kind of a bariatric surgery in such patients, even no point of referring them also. So we see a lot NASH-related cirrhosis nowadays. In fact, to bring it out, the NASH-related cirrhosis is more common than alcohol-related cirrhosis in India. 55% is NASH-related cirrhosis, 43% is the alcohol-related cirrhosis, and rest are miscellaneous cause. So one thing that, and I just want to ask Sachin, in your practice, if a 44, 45 years guy comes to you with recently detected type 2 diabetes by Dr. Chauhan, he has a BMI of somewhere around 43. That's how most of the North Indian Punjabi guys look like. And he wants to lose weight because his girlfriend has told him. So what is the choice of procedure now you want to do? Whether you want to do an MGB or a sleeve? And and second question is there any specific things you look to decide between MGB and sleeve?
Again, as you said, the criteria for sleeve and MGB is again the weight. As a surgeon, you would know that anything crossing 40, MGB would be relatively better for the patient. But what happens, patients come with a funny attitude कि सर मुझे इतना ही weight lose करना है, इससे ज़्यादा नहीं करना. That is a challenge in our country. They don't go by any scientific data or guidelines. I had a patient who said, sir मुझे इससे नहीं कम करना है. I heard with MGB it reduces drastically. What is my next option? So the options put to them are very clear. With sleeve gastrectomy, you will lose a certain amount of weight, which the statistics can show. You can increase the weight and become a stagnant weight. But after that, there is a criteria that maybe drugs can help you if you don't want to go for a surgery, or we can convert it to an MGB later, which is being done in our country. Now, converting from an MGB later, you also know, it gets into an RY, is again a complicated mess. So we explain both these criteria to the patient, and in any practice, if you come, most of our patients, unfortunately, come with limited knowledge and with a pre-expected notion that I want only this much weight. I had a lady who said कि मुझे exact 88 आ रहा है, ना उससे कम ना उससे ज़्यादा. And it was such a difficult job not to smirk or smile, and she said there's one surgeon who said इतना ही मैं लेके आ जाऊँगा. I said, madam, you should go back to the surgeon, thank him and get the job done. So, you know, as you said, it's very difficult to explain to the patient, but it's your fundamental reason and your responsibility to tell the patient with which procedure you will get a benefit, which procedure will give you the best outcome, which will give you the weight gain, which is controllable, non-controllable. These are the plus and minus, the regain and the redo. These are the 6 things which I explained to the patient completely.
Dr. Jitendra Saxena.
Sir, my question was for weight reduction, non-surgical procedure. Part of this question was asked by Dr. Vipul about the endoscopic gastroplasty. The other option of the balloon, sir. Recently, sir, a young lady, maybe 35 or so, she came to me. She said, I want weight reduction, and I want it in a manner that nobody in my family knows. Okay? Yeah, so she especially she didn't want her husband to know. And she had heard of balloon. And we all know there are doctors who are doing balloon.
Even we are doing balloon?
Yes, sir. You are answering. Yeah. So, can we offer this? Because normally a surgeon would definitely offer a sleeve resection or the gastric bypass surgery. Very often these ladies come to us and they want a procedure to be done. They don't have to stay in the hospital. Nobody in their relative should know. And then the job is done. Sir, वो मेरे पास आई बैठी जब उसने मुझे बताया तो किसी को पता ही नहीं चलना चाहिए. मैंने कहा देख पता तो देख ऐसा है शायद ना भी चले, लेकिन बाय चांस कभी तेरे पेट में दर्द हुआ और तेरा हस्बैंड तेरे को अल्ट्रासोनोलॉजिस्ट के पास ले गया, वो कहेगा कि इसके तो पेट में गुब्बार है. तो उसको सुन के वो थोड़ा घबरा गई. मैं कहता जो भी करना है, you do whatever you like, but you have to take either your husband or anybody in the family into confidence and get the procedure done. So this was not only a question, जो मेरा साथ जो experience हुआ और जो मैंने उस patient को जवाब दिया वो उसके भी था. मेरा प्रश्न यही है कि क्या बैलून का हम ऑफर कर सकते हैं ऐसे पेशेंट को इंस्टेड ऑफ सर्जरी. मे बी पेशेंट के रिलेटिव्स को भी होता है, इट्स लेस कॉस्टली, पेशेंट को ज़्यादा देर रुकना नहीं पड़ता. चाहे एक ही दिन रोकते हो आप स्लीप में या बाईपास में, इधर तो पेशेंट को बैलून लगा वो शाम को घर चला जाता है. तो उसी लिए my question is about that only. Can we offer this?
So intragastric balloon has advanced to quite a good numbers in India, and presently Lurian is a company which is doing good in this business. Whenever a patient comes for non-invasive procedures like I don't want a surgery done, it is very important to tell them with intragastric what exactly you're going to go through. So, one is the cost price, which is roughly 3.5 lakhs for the balloon itself. You just come, swallow the pill, the balloon gets inflated, we take an X-ray and the patient goes home.
Mic on karo bhai.
Very good. But the only issue with intragastric balloon, it's a heavy balloon in the stomach causing an obstruction. If the first 5 days the patient tolerates, well and good. Otherwise, I've seen about 30 to 40% come back after 4th day that with heavy burping, it is becoming embarrassment. I cannot take it. Aap isko nikalwa do. And so we have to tell the patient that if you tolerate it, well and good. Otherwise, the 3rd day we need to remove it via endoscopy. The cost price is lost, the money is lost, and there's no guarantee for it. We have a 15 to 20% weight loss after 6 months. After the 6 months, when the balloon disassociates, goes into the colon, you might regain weight again if you're not following it back. So it's a stopgap procedure. Patients opt for it, but over a period of so many years, I have patients saying, "मैंने 2 साल balloon कर लिया, now I want to do the sleeve procedure." So the patient which I had shown was 198 kgs, got balloon twice done, and now he came for the MGB. So intragastric balloon has to be explained in terms of its risk, the cost effectiveness, the effective of its weight, and whether it is really good for you. If the patient agrees for it, well and good.
So, Dr. Saxena, intragastric balloon is good. In one scenario, I will say, if a young girl, if she is going to be married, and suppose if she is 100 kg weight, and she doesn't want surgery, she is ideal case for intragastric balloon. You can put a balloon, she will lose maybe 20 kg weight, and she can go for marriage, and then she has to maintain. So that is the right indication of intragastric balloon. One maybe another, but that is one indication that I know.
डॉक्टर पदार, आप डॉक्टर किरण की भी सुन लीजिए जरा.
Sir, if the patient is young female and obese and goes for bariatric surgery, and if she after that she wants to conceive, so how much time she should wait for the pregnancy to and so that we can advise her proper contraceptive devices.
15 months.
Huh?
12 to 15 months.
12 to 15
When they get their pre-achievement of the weight.
12 to 15. And she during pregnancy, any extra precaution or any, she can have normal diet and all.
She can have normal diet because that's why that waiting period is there. But some of them do feel a little more extra nauseous than the normal patients. But a good thing because there are studies where infertility also has been a major plus point after weight reduction for patients to get pregnant.
Thank you, Dr. Kiran. Dr. Tulsi sir, so your questions, I'm sure some insightful, short but sweet questions.
Thank you, Dr. Chauhan. So that was a great talk, Dr. Sachin. So a very dear question to me, to probably most of us as well. Remission versus cure or reversal. See, reversal or cure is never a term here. You can never achieve reversal or cure either with bariatric surgery or with any other means. They have to come back. Now, remission, yes, possible, especially in patients who are on low calorie diet. You know, calorie is less than 800. This is what the recent study, that UK study, which is known as the direct trial, which was done, less than 800 calories probably. Even in that, who had a calorie, intake of just 800 calories, just 50% of the people achieved remission. We should never use a word known as reversal or cure. There is absolutely no word by the name of cure or reversal in type 2 diabetes, because we know the etiopathogenesis of type 2 diabetes is not only the insulin resistance, it is the beta cell dysfunction, the alpha cell dysfunction as well, mitochondrial dysfunction. So, to cut this thing short, tell us about, this, when you say that it is a cure or a reversal, that means it's a permanent cure, which can never be achieved, neither in type 1 nor in type 2 diabetes.
Question.
So, but there are just two things where you can have remission, or maybe I would like to use the word reversal in gestational diabetes. In patients who have been on steroids, see, if you withdraw those or drug-induced diabetes, maybe some amount of reversal or remission may be achieved. Talk us about remission and reversal, sir.
So I
forget about what the British Bariatric Society talked about. Reversal, forget about the American Bariatric Society, reversal is never an option here.
So here I beg to differ because these are statistics, they are not just hearsay, they are evidence-based medicine. And as I said, we're not looking at American, forget American. Punjab is super obese. right? You can see the pandemic today, the statistics. Dr. Jammu is a renowned surgeon, just a pure general surgeon who went into laparoscopy. As you said, you love diabetes. He also lost his father to severe diabetes and cardiac arrest. He himself is diabetic, controlled in what is it? But the largest series ever presented to the world was Dr. Jammu, for which he's done 13 years of follow-up where vis-a-vis of just letting go surgeries and not following up. Unfortunately, most of the surgeons don't have the patience to do a follow-up or to present statistics. That's where we lose. So I beg to differ, because this has been now proven in the world. Not just 6 years study, 20 years study by Dr. Rutledge has been presented. That is why the Diabetic Society accepted his studies, where in 20 years, for some patients, diabetic medicines did start again. If we don't say that as a cure, if a patient is not using medicine, HbA1c is hovering between 5 and 6, his mean glucose blood is 115, his LDL is coming into control, this would translate into a certain amount of word cure or resolution, because you cannot as a physician achieve this without medicines. Can you stop the medicine, sir?
We cannot stop.
Exactly. So the point here is the surgery made these patients stop the medicines. That is the evidence.
Agreed.
Right.
But can this cure? Can the
As I said, we are too young.
Where is the data?
It is presented, sir. That is why these data have been presented in statistics. These are the statistics which have been presented. As I said, this is a very huge discussion.
Can you share that?
Yeah, I got it on WhatsApp. I'll share it to you. Definitely.
So this was how many years data?
20.
He said 20 years.
20 years.
So I think Dr. C.
By Dr. Rutledge, who started in 97, sir.
20 years data.
Yes, sir.
Reversal of diabetes.
Yes, sir.
Why I said that, Dr. Sachin, was that the ADA said never use the word reversal.
So
by
now
any means.
Times are changing, sir, including the Indian Diabetic Society, including the Federation of International Diabetes Society are using this word. But please remember, again, this is not a fight between cure, resolution, revolution or anything. Understand care and cure. That is more important. Can we stop the later complications? How many medications have stopped cardiovascular problems or amputations in the later stage? Whereas this, with obesity, has stopped these major complications. We look into not the smaller aspects of HbA1c or LDL. We're talking about the broader aspects.
So would you say at
macro and microvascular
at least a 10% reduction in body weight would probably transform into this?
See,
and talk us about the re-remissions or the reversal. There's a new word to coin today by Professor V. Mohan. He's talked about the re-reversal and or I would say re-remission. Talk us about this re-reversal.
Sir, as we have told, there are two types of surgeries, resectional and diversional, right?
So, no sir, re-reversion.
I'm coming to that. So when you do a resectional surgery, you cannot optimize the control of weight in that, because the studies have shown there is an increase in weight. But with MGP or a little harsher gastrointestinal like low and wide, the weight has never regained. So, even as a patient comes to you,
I thought there is a honeymoon period here. Whether you are going to the Roux-en-Y or whether the sleep gastrectomy.
So there is an immediate weight loss in 10 days.
There is a honeymoon period here.
No,
honeymoon phase.
Thanks, sir. Whenever we do a bypass, the results are extremely impactful and in lesser days. In 10 days, a patient loses about 6.5 kgs in MGB. In sleep, 10 kgs in 1 month. And ultimately, the criteria again arises.
So, Tulsi, we have two more speakers.
Whenever we talk to the patient, we never promise cure. We never promise your diabetes will be cured. We only say it will get better.
Absolutely.
Because, sir, again I'm telling you, the whole criteria to present this is there is resolution, there is reversal. But how many of a surgeon can actually wait till 80 years for one patient? Not possible.
I think you should not tell the patient it will cure. It may does long-term revision.
The better word is it will get better.
Yes.
Sir,
That's why I say.
sir, I will take only a few minutes.
Sir.
Just a correction. When we say guarantee our patients कि हम ये कर देंगे वो कर देंगे तो हम पहले तो ये कहते हैं कि भाई हमारी कोई गारंटी नहीं, अपनी कोई गारंटी नहीं।
बिल्कुल सर।
दूसरी बात ये है कि as long as you maintain your weight,
Correct.
if you reduce 15% or more of your current weight, there are chances. We can give them a figure.
Yes.
60% chances,
Yes.
maybe 70% chances,
Yes.
and maybe 80% if you reduce 40%, 30% of your current weight. That is our perspective.
जी.
तो मैं तो एक लाइटर टोन में कहना चाह रहा था कि गैस्ट्रिक बलून, एज यू वर सेइंग, मुझे याद आ गया कि मिले ना फूल तो कांटों से दोस्ती कर ली। याद है आपको?
बिल्कुल।
मिले ना फूल तो कांटों से दोस्ती।
अनोखी है।
अगर हमने
अनोखी रात
नहीं किया सर्जरी तो चलो बलून डला दिया। थैंक यू सर।
So, just to answer that last question, generally मैं patients को balloon नहीं recommend करता हूँ, ना surgery. It all depends on what the patient's criteria and what he demands. Now, for that patient, I told you there is a lady who said I wanted only 88. ना उससे कम, ना उससे ज़्यादा. And some surgeon has advocated, a very good surgeon. I said it is not possible. I cannot do it. So you have to be true to yourself, true to your profession, whether you're a medicine or a surgeon. You can't promise the world to them. There's no guarantee.
Dr. Ankit, I think you stole the CME today, but Dr. Sachin, I said. No, I said, Dr. Sachin, you stole the CME today, but I have to ask a question to Dr. Ankit. And my question is, if you have a big prostate, 140 grams, and you want to use a holmium laser, what are the chances that the patient that you are operating upon will end up with a stricture and with a lifelong calibration for the rest of his life?
Okay. So to answer your question, the stricture was very common in the scenario when we were doing TURPs because we were using electrical energy. In HOLEP, there is no electrical energy that is being transmitted inside the urethra or any prostatic fossa. And 140cc prostate, I can do holmium laser enucleation within 90 minutes because the principle here is very old that was being used in previous generations, that you just go and enucleate the prostate, push the lobes inside the bladder and morcellate those tissues and it will come minced out. So first thing, the stricture develops when you insert the TUR sheath forcefully or you don't lubricate the urethra properly. But the most common factor for stricture was electrical energy and that has been ruled out while we using holmium laser. So the chances are very less, I'll say less than 1%, but still the chances are there.
Thank you. I wanted to ask you a question because you should not go away with the idea that it was only one CME. even Dr. Tulsi, the master, did not ask you anything.
The topic of diabetes is so vast.
Now we are done, sir. Now we are done. Sir, over dinner. I would request Dr. Emil Kalra, sir, Dr. Tulsi, Dr. NK to please